شكرا دكتور رياض. قصيدة رائعة. شكرا جزيلا. It's my pleasure to introduce our speakers and moderators for our final session, which is going to be discussing innovations in endocrine disease and pharmacology. So can I ask our distinguished speakers to please come to the stage? Dr. Mohammed Sher Khan, Dr. Nawal Ibrahim, Dr. Furat Wahab, Dr. Ahmed Hassoun, and the moderators for this session will be Dr. Hala Al-Ubaidi and myself, Dr. Tara Al-Khalil. Thank you very much.
Assalamu alaikum, and thank you very much for staying to the last session. I'm happy to introduce my colleague, Dr. Mohammed Sher Khan, pharmacist in education, BSc Pharmacy, MBA in Edinburgh Business School. He graduated in 2009, International Visitor Leadership Program in the USA in Politics and Economics. He's also the winner of BAU International Award in 2024. And he's also a spokesman for Iraqi Pharmacists Association in Iraq for the last 2 years. His lecture is about Iraqi pharma market and overview. Dr. Mohammed, please.
Thanks a lot, Dr. Hala, and thanks for everyone. So my lecture today, it's very general for today, and I think it's with interest for everyone here. Maybe most of the attendees here are medical doctors, sorry. So with each one with his interest, with his therapy area. But today we will try to answer a question of what is the Iraq in terms of public health and in terms of pharma market looks like. So it's very important for any specialist in the health sector inside or outside Iraq to have a little bit of a review about Iraq. And especially it's very important for the decision makers in Iraq in the public health and the pharmaceutical industry. First, if you don't know, we are 45 million in terms of the population, and we are one of the most growing population across the planet. The growth of the population of Iraq is about 2.24 annual, and we are ranking globally in the ranking number 34 in terms of the number of people inside Iraq. Our national budget or governmental budget is 150 billion. And we have a lot of good news in terms of the UN SC decision removing Iraq from the required procedure by the UN Charter 7. European Union removed us from the countries with the risk of the money laundering and extra. For our private sector, what does it mean, private sector? Means the economy of selling pharmaceutical products in the private sector, in the pharmacies, in any private institution, rather than the public hospitals inside Iraq. It's growing annually and year by year about 20%, and that's why from the economy perspective, we are considered one of the most growing countries in the region. The size of the private and the tender sector inside Iraq, it's about $4 to $5 billion. Is it big or small or what? I will give you an example. For example, Saudi Arabia, which is the biggest market in the region, the market size is about 11, but we are larger than, for example, the Emirates market. The Emirates market, it's about 4.5 billion. Kuwait market is about 1.6 billion. Algeria, it's about 2.5 million, and etc. From the economy perspective, the total economy, we were number one in 22 in terms of the growth of the economy. We were 9.5% growing, but actually in 23, Saudi became, because of their new legislations and policies, became the number one, and we are number 2 in 23. 24, we have no idea. As I told you, we have about 1 million and more than 1 million births per year. So, as I told you, we are one of the most growing populations across the planet. About the GDP is going to be very growing and very promising, especially when we are talking about 23 and above. And our GDP, it will be reach about 345 in 2029. And also GDP per capita, also it's very promising, but it's still behind a lot of the oil countries in the region. We are one of the most young communities among the planet. Actually, more than 70, number one, one of the most growing population and one of the most young population across the planet. We will be 70 million by 2050. Imagine 65 of the Iraqi population, they are just below 30 years. 65% of the Iraqis, they are below 30 years. Baghdad constitute about 1/4 of the population, more than 10 millions. How is the health system looks like in Iraq? Unfortunately, till now, there is no health insurance in Iraq. They have started, but the Iraqi citizen paying about 60% of Iraqis, they are paying for their health service out of the pocket, from their pockets, while the government covering by their tenders and by their the public sector hospitals and centers, they are covering only 40%. And if we will compare that to other countries, for example, in Saudi Arabia, in Iran, 35% they are spending from out of the pocket, from their pockets. Jordan 30%, Turkey 17% only, while Saudi Arabia only 14%, and Kuwait 10%, and I think Emirates also between 10 to 15%. For the MOH total budget, we have a relatively big budget, $7.5 billion, the budget of the MOH inside Iraq, which is constitute about 5% from the national budget. The Ministry of Health in Iraq is spending on by tenders for the tender for the public sector. They are spending nowadays about 1.25 billion, and they are buying pharmaceuticals, medical appliances, laboratory equipment for the tenders for the public sector institutions, including the public hospitals and primary sector units. Fast fact regarding the tenders between 23 and 2023, the local manufacturer is growing. They are getting more tenders inside the Ministry of Health, and the new policy for the government is to support the local manufacturer. Kimadia tenders, they are doing 30% of the tender of the MOH is going to the anti-cancers, and about 23% to the systemic anti-infective, unfortunately. 13% going to the metabolic and anti-alimentary medications. What is the MOH institutions inside Iraq? Actually, the Ministry of Health and the system of the health in Iraq is operating from the capitalism and the old regime of Iraq, which is the government is paying for everything, and we have a lot of public sector institutions and hospitals. We have about 339 or about 340 total governmental hospitals, while we have 207 private hospitals, and we have about 53,000 beds, while the intensive care beds is only 1,180. But guess what? In Iraq, there is 1.7 million operation or surgical operation annual, which is very high number of operations. And guess what? 14 million visits annually to the emergency units. Emergency units inside Iraq is for free, so anyone can go to the emergency units. That's why we have about 14 million visit, and we have about 3,000 primary health care sector. Hospitals, the private hospitals in Iraq, we are under the needed number for the population. And as you see, the concentration of the private sector hospitals in Baghdad and somehow in Sulaimaniya, Erbil, Kurdistan. And nowadays they are growing in Karbala and Najaf. We have something very special in Iraq for the companies that they are importing the medicines in Iraq. The syndicate or association of pharmacists, they are controlling that by opening, it's like the companies or commercial companies that called scientific office. We have about 600 scientific offices inside Iraq. They are importing the medications from the outside, all the type of medications and appliances, and they are selling it to the hospitals, to the tender sector or public sector and to the private sector. We have about 450 drugstores, and we have about 13,000 pharmacy inside Iraq. The private market, as I said, it's one of the references, the AMS, talking about that. The private market inside the pharmacies, it's about 2 billion, and as I told you, it's very growing. The companies inside the Iraq, that the pharmaceutical companies, the number one selling products inside Iraq, they are Jordanian companies, and then
3 minutes, please.
Okay.
Thank you.
And then the American companies, then the Indian companies, then in the fourth ranking, the local manufacturer. The most selling brands in Iraq concur. Number one, Dofaston, Glucophage, Citavia, it's anti-diabetic. And you can imagine the trend for Iraqis, especially for Iraqis doctors in the prescription. And here the market inside about ITCs, the number one, anti-alimentary metabolism, cardiovascular system. This is the categorization of the medications that the people in Iraq they are getting, or it's categorization also of the prescription of the doctors. Anti-alimentary metabolism, number one, cardiovascular, systemic anti-infective. We are consuming a lot of anti-infective, then the sex hormones and so on. And also, if we will go by more, it's ATC2. We are consuming a lot of cephalosporin, as you see, 82 million annually, and then non-narcotic analgesic, broad-spectrum penicillin, anti-rheumatic, non-steroidal, and so on. Number one selling companies, Pioneer, it's local manufacturer, then AstraZeneca, then Ajanta, it's Indian, Al-Duwaliya, it's Jordanian, then Sanofi, Hikma, and this is the ranking for 23. The most visited, and this is the last slide, the most visited specialty in Iraq, they are the gynecologists. Why?
Doctor,
because
Mohammed,
it's
1 minute, please.
okay.
Thank
because they are considered also as the internal medicine, as a cardiologist, as a psychiatric in the rural area. That's for the females, because of as you know, because of the culture of us in the rural area. And then the number two in the priority, internal medicine, then general surgery, orthopedic, and etc. I want to say something. قصة نجاح الإمارات لا تروى في دقائق. فكرت أنه أخلي كم سلايد على دولة الإمارات. بنية تحتية متقدمة، استثمرت الإمارات بشكل كبير بنية تحتية متقدمة للرعاية الصحية وتقنيات الرعاية الصحية، برامج وطنية للصحة، تطوير قطاع الأبحاث الطبية وتعزيز التعاون الدولي. وإن شاء الله بمحاضرات جاية راح نبحث بهذا الموضوع أكثر. وتحياتي لكم، شكرا.
Our next presenter is going to be Dr. Nawal Ibrahim. Dr. Nawal Ibrahim is a consultant endocrinologist and internal medicine. She is currently a consultant at Royal NMC Hospital in Sharjah and a fellow of the Royal Colleges of Physicians. Her presentation will be thyroid disorders in pregnancy, recent guidelines, and clinical implications. Please help me in welcoming Dr. Nawal to the stage.
Assalamu alaikum. Good afternoon, everyone. So I'm going to talk about thyroid disorder in pregnancy, and mainly to talk about physiological changes during pregnancy and why it's very important to recognize thyroid dysfunction and how you interpret, understanding the current area of controversy. Where is it? Okay. And thyroid autoantibodies, pregnancy complications, and explain why there's no consensus on the diagnosis and treatment of subclinical hypothyroidism in pregnancy and isolated hypothyroxemia, some clinical cases. So complex hormonal and metabolic changes during pregnancy, thyroid gland increase in size and increase in iodine requirement, and also TBG increase by 2 folds, stimulating TSH by HCG. So consequently, major professional organizations like American Thyroid Association, Endocrine Society, and European Society recommend the use of trimester-specific and assay-specific reference ranges for maternal serum TSH and T4. So so thyroid receptor expressed between in the fetus between 8 to 10 weeks, and most studies reports that it starts producing thyroid hormone by 18 weeks. That's why the mother of hypothyroidism should be on full replacement before week 16. Okay, so case 1, a pregnant woman, 30 weeks. شو أسوي؟ هيجي؟ يكون شوية بعيدة؟ هذا استخدمه. Okay. So 30 weeks pregnant, free T4 is low and TSH is normal. So this is completely normal, no action needed. And so this is the ATA guideline in 2011. Of course, there is an update, but just showing the example of trimester-specific reference ranges. So tandem mass spectrometry is precise, but not readily available. So alternatively, you can use total T4 or total T3. It's more accurate than free T4, especially in the 2nd and 3rd trimester. And now the recommendation in 2017, so we should aim TSH 0.0824 preconceptually. And I just found a study recently done in Iraq. The TSH, according to the trimester, and in 3rd trimester also 4.5 was acceptable. UAE TSH up to 3.3. So this is the study. So hypothyroid so overt hypothyroidism account for 0.3 to 0.5 of screened women, subclinical 2 to 2.5, some studies up to 6%. So it has adverse effect both on mom and baby, of course, miscarriage and neurodevelopmental delay. So this is a study in Argentina, 150 consecutive pregnancies of 114 women. 99 of them were euthyroid during pregnancy. All of them were on thyroxine replacement, but 51 of them were under replacement. So what happened for euthyroid patients, 4% had pregnancy loss, while the 0.4% had a pregnancy loss in under replacement, and that was statistically significant. Subclinical hypothyroidism with TPO antibody has associated with adverse effect on both mom and baby. So low-dose treatment is enough, of course, according to TSH and body weight. So why there is lack of consensus? Because the trials we have either late start, like after week 15 or 16, and a recruitment of very mild subclinical hypothyroidism, TSH between 4 and 6, and variable assessment of TPO, and also myriad causes that influence childhood neurodevelopmental between age 3 and 5. So meta-analysis of 9 randomized controlled trials and 13 cohort study of 11,000 patients showed no statistically significant differences between levothyroxine group and control group in all primary and secondary outcomes. I'm going to show you more studies, but this was very large. So given the potential benefit over the risk, lower TSH range during pregnancy, and also fetal development completely on mother for the LT4, and also minimal risk of low dosage replacement, most experts elect to treat subclinical hypothyroidism when you have TSH between 4 and 10. So this is another study. So all women, 4,000 plus patients, all of them were TPO negative. So between two groups, TSH less than 2.5 and other group 2.5 to 5. So in group A, pregnancy loss was 3.6 versus 6.1. And also a retrospective study of 62 children born to mothers with hypothyroidism compared to control children. So the study showed that those with raised TSH as a group have offspring who at the age of 9 perform 7 IQ points lower than control, and that was statistically significant. So another case, pregnant woman on thyroxine replacement at 11 weeks, TSH is 10, T4 is normal. Are these expected? Of course, it's very important, dose adjustment at time of conception. And also, we have to check some medication affecting the absorption of thyroxine. I'm coming to that later. So yeah, full replacement should be before the week 16, 2 to 2.2 micrograms per kg per day. And during time of conception, we have to increase thyroxine replacement, some advocate by 30%. So when you have to check TSH for every 4 weeks until week 16, and then after that 4 to 6 weeks after any dose adjustment at any time. And this is I mentioned. Yeah, who should be screened? So we don't have time to go through all of them, but history of family history of thyroid disorder, goiter, age more than 40, BMI of 40 or more, and etc. So another case, 29 weeks pregnant, TSH is high. So of course, adherence you always have to check, and also iron and calcium supplements, it has to be separated by at least 4 hours. PPI also affect the absorption, some herbal medication, and also celiac disease can affect the absorption. So let's move to overt hypothyroidism, which carries both maternal and fetal risk, should be treated. While subclinical and GTT, gestational transient thyrotoxicosis, should never be treated. The second one will completely resolve after week 18. Account for 0.2% of pregnancies. It has both effect on baby and mom. So on mom, very important cardiomyopathy and thyroid storm. It's very rare, but mortality rate is very high. So HCG greater than 100,000 can increase free T4 by 30 to 60%. So like GTT, Graves' disease may improve after first trimester due to immune suppression effect of pregnancy. So it's very important to distinguish between them. How? History of thyroid dysfunction predating pregnancy, or any symptoms of hypothyroidism, elevated TSH receptors, and also something important, ratio between T3 and T4, which is in Graves' disease more than 20 to 1, while in GTT, because, for example, of nutritional status, poor nutritional status, that's why conversion of T4 to T3 in the peripheral tissue is decreased. So I'm just trying to, if overt hypothyroidism diagnosed prior to pregnancy, please advise to postpone pregnancy until euthyroid after definitive treatment and replacement therapy. Do you try and stop antithyroid medication? Yes, we can. Of course, we have to check TFT on weekly basis in the first trimester, then monthly. But when patient already had methimazole, 12 to 18 months, and normal TSH on very low dose therapy, and TRAP is negative. If hypothyroidism recurs after discontinuation, In the first trimester, start PTU. After that, methimazole, recommended.
Dr. Nawal, 3 minutes, please. Thank you.
Okay.
3
So
minutes.
I'm going just to this case is more important. Yeah. So email from medical colleague about a lady 30 weeks pregnant with a T4 above 100, T3 25. So see this patient in a month in the clinic. Of course, alarm bells, what will be diagnosis, and also risk of, 4 weeks is too long, risk of thyroid storm. So, so urgent clinical review organized. Patient was markedly clinically toxic, and she was short of breath. Of course, we have to worry about cardiomyopathy. Patient was admitted, and T4 was reduced after 1 week of treatment. Here, why I mention this case is very important, MDT. With a fetal-maternal obstetrician, decision made to be admitted, echo were normal, and monitoring of the baby, heart rate was 150 to 170. So she developed small bleeding on the balance decision not to deliver for 48 to 36 hours with a close monitoring as inpatient. So in the MDT, we discussed the role of steroid.
Dr.
So further
Nawal,
small bleeding.
1 minute, please. Thank you.
Okay. So, so a patient was successfully, electively cesarean section was successful, and patient had no complication. So this is the baby. Unusual for Graves' disease to present in the 3rd trimester. Unusual for pregnancy to have proceeded apparently uncomplicated to this gestation. And management requires consideration of thyroid status of mom and baby. Case highlight the importance of the MDT. So apply gestational specific normal ranges when interpreting thyroid function. Discuss pregnancy plan with women of childbearing age with thyroid disorder. And for thyrotoxicosis, current guidelines suggest PTU up to 1st trimester, then Numercazole. Be aware of thyroid storm. There are so many slides about thyroid autoantibodies and steroid. If you have any question, you can ask me anytime. Thank you very much.
And now I would like to welcome Dr. Farad. He's a consultant in endocrinology and internal medicine at Royal NMC Sharjah. He's also a fellow in Royal College of Physicians. His presentation will be on obesity, fact, and tips. Thank you, Doctor.
Thank you very much. Now, it's very challenging to talk about obesity in the next 15 minutes. It's like asking a patient with obesity to lose 10 kilos in 10 minutes. So basically, I have no disclosures. So basically, this is the kind of theme of the talk. Start with the definition of obesity. So we know that the obesity is an excess of visceral fat. And for this reason, sometimes they change the definition of obesity from obesity to ABCD, which stands for adiposity-based chronic disease. And it's chronic, and it's non-communicable disease. And in the next few slides, I'm going to talk about why we have to consider obesity as a disease. Because many people think that obesity is something trivial, and many people get stigmatized because of it. Because they think you just need to go try to cut down your amount of carbs and do some exercise. And it's not as simple as that. So basically, why the WHO considered obesity as a chronic disease is because it fulfilled the criteria of disease. The American Medical Association defined the disease as impairment of the normal functioning of some aspects of the body with characteristic signs and symptoms. And obesity or overweight fulfill all these criteria. There is change in the energy expenditure, and it's also appetite dysregulation, resulting in signs and symptoms like breathlessness, joint aches and pains, you name it, as well as results, if it's not treated, ends up with complications like type 2 diabetes and some kind of cancers. And it's a global issue. It's a global epidemic. There are more than 800 million people worldwide lives with obesity. And of those, that's in adults. In children, 175 million globally. And unfortunately, in spite of these figures, yet 45 or almost half of them, they escape or they are not diagnosed. And you can see the hot areas in these slides. These are where we find like the prevalence is quite high with obesity. Now, I'm going to skip a slide for the sake of time, generally speaking, and it's associated with high morbidity and mortality. It's been estimated in 2019, almost 5 million people died because of obesity. 50 million died, but of those 5 million died because of obesity and its complications, generally speaking. And WHO, as I mentioned, estimated that this is a globally epidemic and associated with more than 200 complications. And these complications, you can see from the slide here, the whole body can be affected. It has implications on the metabolic, mechanical, and mental status as well. And you name it, all these illnesses associated with it. We heard from one of the speakers yesterday about the effect of obesity on asthma, generally speaking. And it's associated with high mortality rate. So I highlighted this lower part of the slide. If a person has BMI of more than 40, then the life expectancy is reduced by 20 years in men and 5 years in women. And in spite of all these figures, we still showing or coming across clinical inertia. By that I mean that, and these figures are from the States, that those who have obesity, only 20% has been kind of like diagnosed or come across. It's not like treated. And of those who received some kind of treatment, only 1.3% have or prescribed anti-obesity medications. And it's also important to know why people put on weight, generally speaking. In simplest way, it is like imbalance between energy intake and energy expenditure, generally speaking. But it's more than that as well. There are neurohormonal changes, socio-economic factors, as well as some genetic factors. And medications contribute to the outcome of obesity. And the brain also plays a pivotal role in controlling the energy expenditure. Now, we know that the levels of energy expenditure, there are 3 levels of energy expenditure. If we feel hungry, then we start eating. And what stops the eating are hormones. So the hunger hormone is ghrelin. Ghrelin comes from the gut, from the adipose tissue as well. So this is the homeostatic eating process, which is the normal process. Everyone, if you feel hungry, your body start to release ghrelin hormone. But what stops person from eating is where's marker? Yeah. So this is So what stops person from eating are these hormones, the gut hormones. So these are the gut hormones on the left-hand side of this slide. That comes from the gut, as the name indicates, and the other parts that can also produce. These gut hormones, they increase the satiety in the brain, which is the al-ishba'. So these are the gut hormones. And it's very important to remember this slide because the medications I'm going to talk about are based on these gut hormones. The other name are incretins. Now, so this is the first process of eating process. Now, on top of that, the second level is eating for what we call for pleasure. So this is also controlled by different hormones, and these are based on the production of dopamines. So it gives you the kind of push to eat more. Like if you go for any restaurant and got sweets in front, and then okay, that's nice. I'm going to have a little piece. And this is controlled by dopamine. And then there is also the opioids, cannabinoids receptors, which give you the liking. You love to eat. So these are two processes. And to control this, we have what we call the executive function. So if you have a plate of sweets in front of you, and then you decide, oh, am I going to eat it or not? I'm going to take one piece or two or more. So these are the process. So this is kind of all levels of the levels of eating process. So it's more complicated than and this is why people suffer with these. So now what happens in people with obesity? So this is the normal process I mentioned earlier, the homeostatic process, where...
3 minutes, please, Dr. Furat.
Oh my goodness.
Thank you.
I have a lot of slides, so I'm going to skip this. Now, diagnose and how to diagnose is based on BMI. So BMI and body mass index, as well as waist circumference. Now, these are the. I'm really sorry, I'm going to skip whiz through all the slides. So the cutoff figure for BMI is 24.9. You are overweight if you are up to 29.9. You are class 1 obese if your weight is BMI is up to 35, 35 to 40, class 2, class 3 if it is more than 40. Why this is important? Because the higher BMI, the higher risk and chance of complications. In the Middle East and Asian people, the number is lower, even lower than that. Now, waist circumference is very important as well, because now it indicates the visceral fat. That gives you information about the visceral fat. The way to measure the waist circumference is ask the patient, is taking the lower part of the rib and upper part of the pelvis, and then ask the patient to breathe out normally and then measure it. So if you have waist to height more than 0.6, then the risks of complications of diabetes, of obesity is quite high. So you have to think about it. Now, going through the management, the more you lose, the better the outcome. You can see throughout the slide how this would improve the outcomes and complications. It can even cure diabetes with that and improve the cardiometabolic function as well. And how to manage these people is multifactorial, is multidisciplinary. You have to put efforts on managing these patients because they need help. They need help because of the reasons we mentioned earlier. Now, encourage people to eat less, of course, that lifestyle management, generally speaking, and do more exercise. And these are the recent guidelines from NICE, published in January 25. It just emphasizes this issue. Physical activity, very important. When you talk about physical activity, if anyone in this hall want to maintain their weight, you have to do up to 1 hour exercise to maintain your weight, and that's moderate to intensive. People who want to maintain their lost weight, the obese people, they have to do also more than that. Now,
1 minute, please, Dr. Furat. Thank you.
Sure. Can you give me 2 minutes, please? So there's talk about intermittent fasting as well, which is also good. These are medications. We are talking about the Xenical, but the most important one I want to talk about are these medications, the semaglutide and tirzepatide. These are GLP and dual action, the GIP and GLP agonists. So they work on the stomach, on bowels, and these medications that slow down the bowel movement, and improve satiety, increase the satiety in the body. Now, this is one of the earliest medications. Semaglutide is recently given once weekly with the non-side effect, mainly people you can use for more than 30, but can be used less than that if they have comorbidities. Same applied. And this is how you escalate the dose. And this is one of the studies showing how effective is the medication in weight management. While tirzepatide or Mounjaro has the same kinds of indications, and this is how you escalate the dose as well. And in terms of, these are, generally speaking, managing the obesity or people with obesity with non-diabetic. But people with diabetes, these are also recent guidelines from the joint EASD and American Diabetes Association. They concentrate on using the very high, and intermediate medications, namely the GLP and SGLT2 inhibitors. So again, education, these are the, I think, two more slides. Surgical intervention, what are the indications for bariatric surgery if the BMI is more than 40, or if it is less than that with comorbidities, that's the other indication. This is the future of these medications. Now, the backbone is GLP-1. We mentioned GLP-1 is the backbone, and this, and because, you remember the slide I mentioned earlier, so now the scientists are adding new medications, like they add, for example, here, say they add amylin. This is the new medication. It's called cagrilintide. It will come to the market in this year or the year after. So this work on the muscle, improve the muscle power as well. And we have the triple action. We have the single action, and we have the double action, and we have now coming in soon the triple action medications, GLP, GIP, and glucagon agonist.
Dr. Forat, we are really running out of time.
And this is conclusion of this talk.
Thank
so
you.
The key home message is that please consider obesity as a disease like diabetes and heart disease. And it's very important to give education and new medications in the market coming soon. Thank you very much.
Ladies and gentlemen, after 2 incredible days of insights, cutting-edge research, and very interesting case studies, it is my pleasure to introduce our final presenter and distinguished speaker to the stage. Help me in welcoming Dr. Ahmed Hassoun. Dr. Ahmed Hassoun is a senior consultant endocrinologist and university professor. He is currently the chairman of medicine in Faqih University Hospital in Dubai. He is a clinical professor in medicine, Dubai Medical University in Dubai. His presentation, and he'll be sharing with us very valuable insights on fatty liver and DM, update on NAFLD. Help me in welcoming him to the stage. Thank you.
There is a need for evidence of hepatic steatosis, whether by imaging or by histology, but also at that time it was defined as there is no causes of secondary hepatic fat accumulation due to a significant, for example, alcohol use or using some medication that cause fatty liver or hereditary disorders. But the important things nowadays is they have to change this name from NAFLD to MASLD. And the MASLD is metabolic dysfunction associated steatotic liver disease. And many societies gathered together and ended with this consensus nomenclature, and we're trying to look into, on the left side of your slide, of the slide here, is what we are going to talk about more. There are many other causes of steatotic liver disease as shown in this slide. And this is an endorsement of more than 70 societies for these changes in the nomenclature to the MASLD and all the others, new nomenclatures for the other causes. This is just to help you simplify things. First, you have to have steatotic liver, fat in the liver. Then you have to ask if there is any criteria for cardiometabolic. As probably all of you know, this is like a metabolic syndrome criteria. If there is any one of this, then you look into, is there any other causes that might be contributing to this fatty liver? And if it is not, then this is what we have, the MASLD. Now, after these changes, people were thinking, Can we use the old data of NAFLD under the new muscle-D definition? And there are two important reviews here by the Chinese, one of them by Chinese University, Hong Kong, in China, and they reviewed their data to compare, and they ended with this conclusion that discrepancy is very minimal, and we can still use the NAFLD for muscle-D data. Another important groups from Sweden look into their university hospitals data, and again, they concluded that 99.5% of patients with NAFLD met with the muscle-D, and then we can use the data and the natural history of NAFLD and muscle-D. It's very important. We probably heard about so many diseases today, but probably you need to remember, in addition to what Dr. Furat mentioned, obesity, this is also related to obesity. It is one of the most really common problems that we are facing, and we are going to face more and more with time if we not do anything about it. As you can see in this slide, our MENA region is more than 1/3 of the people have this. So 1/3 of you sitting in this room probably having some early stages, hopefully, of muscle-D. And this is important to remember. Normal liver will go to NAFLD, or what we call now muscle-D, in about 25 or more of the people. And this will progress with time, if nothing done, and depends on the other etiologies and other risk factors, to NASH, non-alcoholic steatohepatitis, and then cirrhosis and carcinoma, hepatocellular carcinoma. More importantly, the cause of death in this group is not the hepatocellular carcinoma. In most of them, it is cardiovascular death because of their other cardiometabolic factors. A few words about the pathogenesis. Accumulation of fat and sugar in our diet and the fat in our diet leading to excess of fat. And this excess of fat with the insulin resistance is seen in these people. And lipolysis of this fat will lead to free fatty acid accumulation and triglyceride in the liver, which by itself will lead to effect on the mitochondria and the endoplasmic reticulum, leading for inflammation, as well as what is more serious is hepatic fibrosis. Look at this slide. This is really, scary. NASH is one of the causes that led to hepatocellular carcinoma, and they were waiting for transplantation. This is from the US. You can see that the other chronic liver diseases mentioned below, they did not have that excess when you compare the proportion relative to 2002. In 2002, you can see it's growing very fast, 24-fold increase for NASH causing hepatocellular carcinoma, needing to go for transplantation. These are the factors that known to be having higher risk for the development of hepatocellular carcinoma. Mentioned here is the duration and type 2 diabetes, obesity, old age, concurrent alcohol and smoking, individuals with FIB4, which is an equation and index we use, and maybe we'll come to it later, individuals with liver stiffness marker, which is done by FibroScan, more than 10 kPa. These are increasing with time. This will have a higher risk to develop hepatocellular carcinoma. Moving to diabetes and the same disease. In diabetes, even more problem. You can see here that in diabetes, globally, we have estimated to be 55% of people with type 2 diabetes having NAFLD, or what we call it now, muscle-D. And you can see our region is more than 2/3 of the people having diabetes will have NAFLD in their, when we investigate them. And this is a study from the US, published in 2021, looking at the primary care clinic that we see, our endocrine and primary and family and internal medicine. They looked to and studied them, and they found 70% of these people with type 2 diabetes have steatosis, NAFLD, and 21% of them have fibrosis. More importantly to remember is that liver enzymes are not increased in the majority of these cases. You can see ALT, AST increment is only 10% in ALT and 6% for AST. Even more worrisome, even the people with having advanced fibrosis, you can see from this slide, the ALT and AST is still not high in the majority of people with fibrosis. This is another new study. They use more sophisticated method, MRI method, to look into diagnosing, and then also followed by fibroscan or MRE, elastography. And you can see also the prevalence in this group. Again, they are type 2 diabetes in primary care clinic. But here they are studying people with type 2 age more than 50, and you can see that the percentage is exceeding 65% with NAFLD, and 14% having advanced fibrosis, 6% having cirrhosis, and 3 cases of this cirrhosis having also cancer of the hepatobiliary tract. Few points about the guidelines. We don't have a way to look into that's how to screen. It's only case finding. And here's some recommended things. I just highlighted 3 of them. Because of the time, we cannot go through that. But I think it's important that when we're talking about artificial intelligence is going to be used also in this field. And there is one study from Washington, in Washington, Seattle. They look into how, if they use the AI algorithm, they found that they miss many cases by not using the AI compared just to case finding in their data. So they ended saying that we are going to miss a lot of early cases of muscle D if we did not improve the way of using, especially depending on AI in the soon future.
Dr. Ahmed, 3 minutes, please. Thank
3?
you. 3.
3, okay. So trying to be faster. This is the
5 minutes from Dr. Mariam.
Oh,
An
thank you very
extension
much.
of further 2 minutes. Thank you.
This is from the American Association of Clinical Endocrinology guidelines about cirrhosis prevention in these people. And just to remember, we mentioned about FIB-4 index. You can find it in the, by the way, in your mobile phone. You can download it and see how easily to calculate, only measuring ALT, AST, and age, and basically and platelets. So you can look into that. If you have FIB-4 index low, then you need to follow up later in the future. Maybe 1 year would be good. And if you have FIB-4 high risk number, as mentioned here, then you need to probably refer to our colleagues in hepatology. Dr. Fayyad is here. He can second that. And if it's in the indeterminate, in the main, indeterminate risk group, which is the index is different, as you can see, then you can go to the next step, and we are doing it now. In addition to our colleagues, we are doing liver stiffness, which we call it fibroscan, and we can do that, and we can also classify them further, whether they are low risk or indeterminate risk or high risk. Usually, indeterminate risk, maybe in the higher range, we are referring to hepatology. In the highest group, again, we are referring to hepatology. Otherwise, we are managing themselves, as we will see later on. This is very simple, and I think most of the hepatologists have this one in their offices and doing very simple. It's like an ultrasound, but measuring elastography. This is, again, a recent one, last year, just published from the European group. I will not go into details because it's similar, using FIB-4 again, and the fibroscan for indeterminate cases. So for the management, it's very important to look into the diet, basically, in people who have this. Very simply, just energy deficit, reduce the calorie intake. The second thing important is restriction of some foods, processed and ultra-processed food, as mentioned here, saturated fat, but also very important, high fructose foods, and adaptation of our well-known Mediterranean diet, which is always good in all prevention, even cardiovascular. And I'm not going to go into details of this, but this is showing that the treatment when you have this, depending on the low risk, indeterminate risk, and high risk. So in the low risk, it's basically you can use any treatment, including the pioglitazone that we use for diabetes management, or you can use GLP-1, as mentioned by my colleague, and SGLT2 inhibitor. But if you have more advanced case, like indeterminate or high risk, then you have to move to the using to GLP-1 that are shown to be having effect into NASH improvement or even stabilizing the case. And this is the recommendation coming from the American Diabetes Association in 2024, recommending as level A evidence that recommendation pioglitazone or GLP-1 agonists are preferred agents to be used in this. In people who have biopsy proven, but not only that, for people who have high risk with a clinically significant fibrosis by non-invasive studies. It's not necessary to have the biopsy.
Dr. Ahmed, 2 more minutes, taking into account Dr. Mariam's extension as
Thank
well.
you.
Thank you.
Thank you. I'm just going back to one of the recent things that we need to add for the new things here is a new drug. The only drug that is already been approved to be used for people with NASH, and I will show it to you according to the study, showing that there is significant benefit in people using this medication, and this is what we call it resmetirom, and we'll see it later that after this study, the FDA approved it in March 14, 2024, to be used in people with advanced fibrosis, but not decompensated cirrhosis. And you can see it here that in MASH group, there is now included in the new recommendation to use resmetirom, as we mentioned earlier. The others here, type 2, the medication that well known, and we touched on it, but you do not need to forget about dyslipidemia and obesity management, which is very important to reduce the cardiovascular complication as well. And I'll leave you now with the take-home messages. NAFLD and MASLD are similar. You can exchange them by the name, by the studies. The discrepancy between MASLD and NAFLD is minimal, and so we can use the data as we mentioned earlier. MASLD is increasing in prevalence, and for that reason, especially in type 2, and for that reason you have to look into and screening and finding these people. Don't look into transaminases. They are most of the time, majority are having normal transaminases. And the cornerstone is prevention. Always prevention is better. Lifestyle changes. We try to prevent this rather than getting the new medication to treat it, which is really having also some side effects. And I would like to main proactive screening and case finding for MASH in people, especially with type 2, for early intervention that will change the disease progression. And last but not least, elevating awareness about NAFLD. And I've been doing this since 2016. About NAFLD is urgent in healthcare, especially given the rising rate of obesity and diabetes, which expected again to strain our health. And Dr. Mariam is here. She can know about healthcare resources to be strained, and by having more of this happening. And with that, I would like to stop here, and thank you very much.
Thank you very much for your attention, very valuable insights, great presentation, and for your presence with us for these last couple of days. We would like to conclude this prestigious event with a final closing remark from Dr. Mariam Mutar. Dr. Mariam, تفضلي. Following Dr. Mariam's speech, we'll take a surah jama'iyya. All of us, everybody to the stage. Thank you.
بسم الله الرحمن الرحيم. مساكم الله بالخير، والحمد لله رب العالمين. بجهود الجميع وصلنا إلى ثاني يوم من جائزة باو والمؤتمر الطبي العراقي في الإمارات، والله وفقنا سبحانه وتعالى حاولنا قدر الإمكان نكرم أهل الفضل علينا من زملائنا وأساتذتنا من بلاد الرافدين مثل ما قلنا. أرد وأقول إحنا في دولة الإمارات سبب هذا كله توفيق من الله سبحانه وتعالى، إن إحنا كدولة إحنا اللي أتاحت لنا الفرصة والأسباب إن إحنا نكرمكم. اسمحوا لي حين في آخر يوم الحمد لله عادة الصورة الختامية تكون كثير جميلة عشان الناس اللي باقين صدق ناس يعني كلنا طبعا، بس هذا البرنامج وهذا المؤتمر العفو ما كان بيستوي لولا البرنامج العلمي اللي توج بأساتذتنا اللي قدموا لنا المحاضرات اللي أكثر من رائعة. فبالتالي إذا حد لازم نشكره هو المجلس العلمي برئاسة الدكتور يحيى. دكتور يحيى تفضل. دكتور يحيى. دكتورة أنا دائما تارا. دكتورة تارا ودكتور مناف. دكتور مناف. المجلس العلمي كله اشتغل واجتهدوا، ولكن دائما مرات حد من الفريق عنده ظروف تسمح له انه يعطي اكثر، فبالتالي دكتور مناف، دكتور مناف، دكتورة تارا، دكتور يحيى، صورة لو سمحتوا معاهم. جزاهم الله خير. المجلس العلمي كله اشتغل، دكتورة هالة، دكتورة شيخة، دكتور محمد، ما شاء الله سووا جهد طيب. بس لما نقول يعني يوم قبل المؤتمر دكتور يحيى أحفاده كان فيهم حرارة وزوجته تعبانة خلاهم في البيت وما طاع يودرنا. دكتورة تارا ساكنة في الشارجة تمت معانا لين الساعة 9 بالليل وإحنا في القاعة. دكتور مناف لغى عيادته وخذ من إجازته السنوية عشان يبقى معانا لين الساعة 11 هو موجود هني 10، والصبح الساعة 8 هو في القاعة. شكرا جزيلا جميعا والله. يعني الحين عندنا دكتورة هالة، تفضلي دكتورة هالة ما قصرتي في ديت قلبك. دكتور محمد، دكتورة شيخة، تفضلوا. منو بعد في المجلس العلمي؟ وينها فاطمة؟ دكتورة فاطمة تفضلوا يا إخواني. شيخة تفضلي في ديت قلبك. كلهم المجلس العلمي ما قصروا، بس يمكن حد فرصة ظروفه أتاحت له أن يعطي في هاي الفترة الأخيرة، ولا كل حد له الفضل. تفضلوا تفضلوا. تاخذوا لهم صورة بدوني يعني. أول شيء معاهم. تعالي شيخ تفضلي. وين وسن؟ أطمن إنك موجودة. شكرا جزيلا. مبروك لنجاح المؤتمر، مبروك لجهدكم. لا يعني أفضل عمل ما شاء الله. جزاكم الله خير. تفضلوا. الله يسلم. أخذ صورة معاهم. أنا ما بوقف عند محمد طويل أبين قصير وأنا لابسة كعب. دكتورة وسن دكتورة وسن دكتورة وسن فديت قلبها، يعني كل حد في اللجنة المنظمة ما قصر، بس دكتورة وسن مرت بظروف نفسية من مسجات كانت تيها وتغطيها عني، ما تراويني إياها عشان ما تبى تضايجني حبيبتي دكتورة وسن. وفوق هذا تشوفون التفاصيل هذه، ميزانية المؤتمر. كنا شوي في البداية محصورين، تفاجأت بدكتورة وسن، أنا ما أعرف أن شركتها تكلمني أنكيتا من المركز عنا، تقول دكتورة أبشرك حصلنا راعي بلاتينيوم. قلت لها والله ما شاء الله مبروك، زقريهم يوقعون. عقب تقول لي تتصل فيه تقول لي دكتورة وسن ما تتكلم ولا تقول لي إن هي شركتهم. بعدين تقول لي دكتورة أنا أشوف اسم دكتورة وسن، كلمتها قالت لي دكتورة يعني اللي سوته دكتورة وسن فديت قلبها مجرد ما دخلت شركتهم الله وفقنا بشركات كثيرة جت ودعمتنا. شكرا دكتورة وسن. وين دكتور عماد؟ شكرا دكتورة وسن حبيبتي وسن.
يعني هذا جزء بسيط جدا عن اللي قدمته دكتورة مريم بتقديرها للجالية العراقية في كل أنحاء العالم. فحقيقة الكلام هذا حتى لا يفي بجزء اللي عاش على أرض الواقع وشاف الشغل والجهود اللي بذلتها دكتورة مريم بكل حب، بدون هدف، بدون غاية، بحب وبتعاون. وأنا كنت في كل اجتماع أقول لهم دكتورة مريم أسلوب يدرس، لأن الجمع بين القيادة واللطافة أمر جدا صعب. كنا عشنا وداومنا في مكانات وقدنا شركات، ولكن أما تكون قوي وحاد أو تكون لطيف ولين، ولكن تجمع بين الاثنين شيء صعب. اللي جمع بين هذا الاثنين دكتورة مريم مطر. شكرا من القلب لدكتورة مريم، شكرا لدولة الإمارات، شكرا لقامات العراق اللي جوي من كل أنحاء العالم، شكرا لحضوركم، شكرا لكل الدعم. وهذا كله نجاحه يعود إلى فريق متعاون متكامل. شكرا لكم.
بعد إذنكم كلكم ناخذ صورة جماعية. طبعا أول شيء كرم حبيبي، تعال وقف جنبي لو سمحت. فديت قلبه كرم والله، حببني في العراقيين كرم. تفضلوا أساتذتنا ناخذ صورة جماعية كلنا. هي صفين. إيهاب ترتب الصور. الصورة بسرعة خوي. كل حد everyone تعالوا لو سمحتوا ناخذ صورة جماعية الكل. هي إن شاء الله. هي واللي برا بعد يا ود محمد.